as part of this series we're recording for Euro PCR Spotlight session, then it gives me great pleasure to chat with Buster House. Buster spent over 30 years in the Royal Marines and ended as a general. And so he's got a lot more leadership credentials than I have. So Buster, thanks for joining us today.
Thank you, Iqbal. It's a pleasure.
So the topic for this session is about how we protect the institution. So we work in large organizations. The NHS is the biggest employer in Europe. So how do we, during this COVID-19 crisis, ensure that we come out of it, not only having served our patients, but protected the reputation and integrity of the institution?
Well, as you say, the NHS is, I think, the second largest bureaucracy in the world to the Indian Railways, and mass has a quality all of its own, not least inertia. There are three messages, really, which I want to tease out. The first is about clear, timely, consistent, and coherent policy. And some of this is driven at governmental level, and so the NHS is, if one was positive, a beneficiary of the government's clarity, but it can still do a lot itself. The second is clear, honest, and timely communication and messaging. And the third is about minimizing the uncertainty which is within your control. Part of the issue of controlling and managing the uncertainty of both patients and perhaps more particularly the million staff who work across the complexity of the NHS is giving the clarity that you can where you can. So, for example, rostering. There seems to be a particular bugbear, the actual way that you manage people's time and the propensity for them to be blindsided at short notice. I mean, you've just changed the employment method and patterns of large numbers of people. It's all been thrown into the air, and indeed the groups they work in are sometimes thrown into the air. Within that change, within that retask organization, there has to be enormous effort for clarity of employment. You need to set out what is expected of people with as much warning as you can, as clearly and consistently as you can, to use people in the best way you can over time. If you don't do that, you're going to burn people out. The next point, and that also applies to really minor, banal things like the way they're fed, the way they have to travel. In the normal circumstances, quite often you'd find junior female staff, because they couldn't park near hospitals, traveling at 2 o'clock in the morning after their shifts to off-site, poorly lit car parks to meet up with their cars. No, you've got to think about all those things that put friction into people's lives when they're already beleaguered, and you've got to make them better.
So I think we've got some evidence there, Buster, that the NHS has taken some action, because they have provided accommodation closer to sites, especially if you're isolating yourself. Most hospitals, but not all, have taken away car parking charges so that you can park. And actually, for example, in our institution, we sent a public broadcast out on Twitter because Uber drivers at some stage weren't bringing people to the hospital, and black cabs in London have been very useful in offering their services. So you're absolutely right that we need to look after our staff.
Well, I mean, that's really heartening, but horizon scanning for all those things and talking and listening to people to understand what the pinch points are and then actively addressing them builds enormous credibility and will help, the reputation of the faceless institution. The propensity when people are under pressure is to talk about them. So, you'll meet somebody who feels disempowered and they'll look you in the eye as a senior consultant, which I know you are, and they'll talk about them. Those people who are doing X, Y, or Z, or rather not doing it. And when I was in that situation, talking to Marines as a general, I'd say, well, I'm them. I am the them, aren't I? So look me in the eye and tell me what needs to be done. And then the really important thing is to do something about it. You've got to trust your people. they're in this. There's a ridiculous metaphor of a full English fried breakfast, bacon and eggs, where the chicken is involved and the pig is committed. Well, all your people are committed, and so you have to honor that commitment by being as honest and transparent and clear as you can with them. If the reality is tough, well, you need to give it to them straight, because only then will you not end up with a sort of dislocated expectation. You need to manage their expectation, but level with them.
Can I ask a question about that? Because we've got a little issue at the moment about PPE, and in particular, if you're resuscitating someone. So it's very timely what you say there, because there is confusion in that the great and the good, for example, the UK Resus Council in the UK and Public Health England can't seem to agree amongst themselves about what the right thing to do is. So you raise the idea of uncertainty, and that uncertainty breeds mistrust. And at the moment, you know, a lot of senior doctors feel that some of the policy decisions are made because of what's available rather than what's actually correct. So you're a military man. What happens when there's a pull between what's available and what's correct for your team?
Well, I mean, the thing you point to is a massive conundrum, isn't it? This is people's lives, and there is enormous fear in these gaps, is there not? And that fear will spread into all sorts of other areas. So it seems to me the absence of a global consensus in this whole thing strikes me as being utterly extraordinary. But let's just look at the UK policy. If the UK policy is incoherent and in disagreement, I think it behoves the leaders within the environments that they control to make the right judgments. That's what you're paid for. Step up, be courageous. And if as clinicians, you know what the right thing to do is, then that's your policy.
That is really that is really useful to hear, Buster, because in fact, certainly the cardiology group at Imperial took a very strong lead on not only developing these sort of teaching resources, but actually doing things on the ground. And I think it harks back to the reputation then, because our reputation both outside of the institution and inside has been enhanced, and the team really believes in us because we've been leading from the front.
Perfect. You know that saying, lead, follow, or get out of the way? You know, if the people who are supposed to be articulating the policy aren't, well, goodbye. And you know, it's easier to ask forgiveness than permission. So ultimately, you have a vast amount of experience and knowledge, and you should draw confidence from that, and then, you know, march on that bearing. So I completely endorse what you've done. Good for you.
Excellent. Now, Buster, you're going to come on to talking about what a good working group is and how you handle them. So tell us something about what a group size that is manageable is.
You know, one of the really important things is that, you know, this is a fearful time. And as people become tired, you know, the environment of the military is one of danger, fear, friction, uncertainty, chance, and death. That's Clausewitz. And what we try to do is to set up procedures. We call them tactics, techniques, and procedures, which manage the fact that people quite often have to make difficult, time-pressured decisions between wrong and wrong when they're thirsty, sleep-deprived, hungry, wounded, frightened, and uncertain. And quite a lot of the conditions which I've just articulated are germane to the circumstances which you are now all operating in, which is why the metaphor of war, helpfully or unhelpfully, is now often used. It's much easier to be brave with people you know and trust. The people that you know, trust, and laugh with become your sort of bulwarks for normality. Preserve the things that are normal and preserve the primary group, and think really hard about how you move individuals and groups such that you try to sustain the structure which bounds their lives and the people with whom they identify.
So if I give a concrete example, then intensive care units are very busy at the moment. If we're supplying extra personnel to intensive care units, your idea would be to actually move a group of people that have worked together before into that unit rather than send one individual off there.
Correct. They need to be sort of somehow talked in. There needs to be some process of introduction, so they're not literally just hurled in at the deep end. The hard thing in that is that people are so busy. The inclination is just to say, here you go, you know, here are your scrubs, get on with it. You know, if you can somehow or other have somebody sits down and just figures out generically the things that if I walked into a COVID ward cold would be the top 6 to 10 things that I would want to know, whether it's in a group of 4 or a group of 6. And that will reduce the friction for everybody ultimately.
That's a bit of preparation, isn't it? Is always good. So the final two parts that you wanted to deal with here were the idea of the non-swimmer, the person who is not adaptable here. Now,
yes.
There's a real problem when we were talking about this, which I raised, was that I suspect in business, you know, if you were not performing, you would actually be one day not let into the building. That's very difficult inside the NHS. So any tips from you on how we deal with the person who up till now, you know, has been going along all right, but hasn't adapted to the real changes that we have, and perhaps has even been difficult in the situation? What would you do?
Well, I'm sure there are people like that. It may be just that they know what they know and they've worked in the NHS for 40 years and just can't adapt or won't adapt. Or they're quite senior in the hierarchy and feel a sort of sense of resentment and entitlement, particularly if they're close to retirement and it's, well, this is deeply inconvenient in this huge bureaucracy. There isn't a tremendous reputation for moving people who really are toxic or uncooperative or difficult. War is the midwife of change. And it seems to me that actually there is both a moral obligation for the HR system in the NHS to now grip this issue, which has blighted it for ages, and to find a way. But if there is an individual who is a real impediment to efficient, effective, and frictionless working, even in these really difficult times, you have to move them. You owe that to the people who are trying their level best in the most flexible manner they can to get the job done.
Very difficult indeed, I think. So I think we'll have to see what our senior management team come up with doing that. I went to a very interesting talk from Disney once, and you know, I was very much for raising the lowest person upwards to get the average higher. And Disney is very clear that that is very hard to do and very inefficient. So what Disney do is actually take the top few and drag them even higher, and that brings everyone else up. And they're very clear that those few at the bottom, they are recalcitrant, they are usually unmoldable, and they will usually be exiting the institution. That's hard in the NHS, but it's something to think about. So the final part was of preserving the reputation, was to actually think about the future. How would you break up the future and deal with it?
There's a natural propensity in crisis for everybody to race in on the thing that's confronting them now. You all, you know, that's how we're wired as human beings. It's the fight or flight mechanism. And that doesn't work. It doesn't work in combat. It doesn't work in any kind of crisis, because some people, we have a metaphor. It's called kiddies football, where everybody crowds the ball. When you watch your 6-year-old children play football, if there are 20 of them on the pitch, they're all on top of the football. What you actually need is people running out on the wings, making and looking for opportunity. And so you have to have structures which deter people from all running in on the issue of the moment. And clearly it's a sort of temporal distinction. And the military has a staff system which has a lineage back to a man called von Moltke, and he defined very elegantly 9 different categories. I won't describe them all, but essentially J3 is the operation now. is what we would call the contact battle. It's the people who are managing the current fight, this 24 hours. You then have another group, which is distinct, which is J35, which does the near future. And they manage the sort of 24 to 96 hours. So you stitch the two together by having these two groups. You know, this is what we're dealing with. This is the problem we've got. And at that point, the near future people say, right, I've got that issue. I'm working it, and I'll make sure it doesn't happen tomorrow or the next day. And then finally, you have a group of people who look a long way out, who are completely untrammeled by the here and now, but are horizon scanning for things like, well, what happens if, you know, COVID-19 is like flu or cold and there is no vaccine for it and people will be reinfected? Or that the vaccine by, you know, Bill Gates's best guess does take 18 months. What does that actually mean? What's the plan if this awful pandemic is controlled, constrained, or abated, to restart all of that? It seems to me somebody has to be looking out, right out to that distance.
Fantastic. So Buster, let me summarize by just reiterating what you said at the start, which was that to protect the hospital, then we really need to have good policy making, and one that doesn't keep on changing unless there's an absolute need to have clear messaging for the wider audience, especially the staff work there, and to try and manage the uncertainty that there is around all of this, which is really all down to leadership, isn't it?
That's the fundamental thing.